Could we put it back to the beginning? Good afternoon. I'm Brian Jack. Thank you very much for inviting me to this meeting. It's a great honor to be here. So some years ago, with the aid of Agency for Health Research and Quality, we developed the Re-engineered Discharge Program over a several-year period and came up with these 11 mutually reinforcing components. The first one, as you can see, which is really the most important component of the Re-engineered Discharge Program, is medication reconciliation and understanding about people's medications. Other things relevant are follow-up appointments and outstanding tests, post-discharge services. A written discharge plan, which if we've added anything to this, is that the written discharge plan is really very different than a written discharge summary. Discharge summary goes clinician to clinician. Discharge plan is something that patients use to care for themselves and their family caregivers use to help care for their loved ones at that time. But also number 9, assessing patient understanding, to do teach back, to be sure that people understand the appointments and all that, but especially the medications and what they're for and how to take them. And then a discharge summary to the primary care physician, and then telephone reinforcement. So this was adopted by National Quality Forum back some years ago as a standard for hospital discharge. When that happened, we said, well, if National Quality Forum is recommending that the RED program be used at all hospitals, why don't we do a trial to see if it works or not? So we did this randomized controlled trial, randomizing 749 patients to usual care or the RED intervention, delivered by a nurse teaching the active component, which is the after-hospital care plan, to a patient at the bedside, where they collect information, package the information, teach the patient, and then use the after-hospital care plan to teach the patient what to do and to communicate that with the source of ongoing care, and then for high-risk patients to do telephone follow-up. This is really before all the telephone call follow-up really started, and maybe it was some of the beginnings of post-discharge telephone call. So the total utilization, both ED visits and rehospitalizations within 30 days, and those in the RED group were highly statistically fewer. What I want to talk about today is the after-hospital care plan, which is the patient-centered tool that is used to teach people what to do to care for themselves when they go home at the time of hospital discharge. We spent a lot of time thinking about health literacy and thinking about how is it that people can best understand this. It's really designed for people at all levels of health literacy. So you can see from this that there's lots of white space and large fonts and pictures and icons and that sort of thing. The medication piece is here, and patients, there's icons about when to take them, why am I taking the medicine, what's the name, in fact, what are both names, how much do I take, and how do I take this medicine. Guess what? They don't want to know about pathophysiology. They don't want to know about mechanism of action. These are the 4 things in lots of focus groups that people want to know about, and it needs to be clear about what to take, why they're taking it, and when they take it. There's also a section in our after-hospital care plan that describes follow-up appointments. So this is for the primary care doctor, the various consultants and various tests. It could be for the INR, the day the bed's going to be delivered and the commode's going to be delivered and the oxygen and all those sorts of things. Then tied to, all in our after-hospital care plan, a calendar. So the calendar is a list of activities that are color-coded to the list I just showed you of activities in the next 30 days. That the patients and their family caregivers need to know about over the next 30 days. And the patients, guess what, really like it a lot. They give them little magnets, this Project Red on it, they put it up in the refrigerator, and they turn it usually to this page, which is, this is what I need to do over the next 30 days to know what to do to care for myself after the hospital discharge. So we asked people about the after-hospital care plan, that this is extremely and quite a bit. How helpful was the medication section? So 3/4 of the people think the medication section is very helpful to them, even though it seems very simplistic to us sometimes. When we categorize by health literacy, you can see first that grade 3 and below, the low health literacy, health literacy is related to readmissions. This has been shown in a variety of studies now. This is one of the first that did it. And by health literacy category, the red is the intervention group, so it's statistically significant in 3 of the 4 categories to lower readmissions, both in the lowest health literacy category and in the highest health literacy category. So across the board, people found it helpful and decreased readmissions. Well, second, some other outcomes is that when we asked people in the intervention group, when is your follow-up appointment, it was statistically significant that people in the intervention group knew more about their follow-up, knew more about simply their diagnosis, knew more about who their primary care physician was. When we asked them, how prepared were you for discharge? The intervention group was higher. Do you understand your appointments? It's higher. Their medications, it's higher. Understand the diagnosis, it's higher. And questions and answers, it's higher. And this is 30 days after the discharge, when a lot of people don't even remember what happened when they're in the hospital. They remembered there was something about their discharge that was different and better. We have then applied Project Red in our hospital in various units. In the first unit that received Project Red, this is a Press-Guinea HCAHPS question, which is instructions were given how to care for yourself at home, was highly statistically different than those patients who did not receive the reinstatement discharge on the same unit and throughout the hospital over the same period of time. So that you can raise HCAHPS scores based upon the quality of the education relative to the discharge using the Project Red after hospital care plan tool. I'm going to talk just for a second about this concept of it's more complicated than you think. And that syndemics are the aggregation of two or more diseases in population in which there's some level of positive biological interactions that exacerbate the negative health effects of any or all diseases, so that there are interactions and the patients are all different. People need different things. We need to identify what those things are. In our red data, so the relative risk for 30-day all-cause rehospitalization, health literacy is 46% more likely if you have low health literacy, 75 for patient activation, depression, 73. Frequent utilizer we've known for a long time is the biggest risk factor for frequent utilization. Male gender, men aren't good at healthcare. We have a whole paper on that if you want to hear more about that. And substance abuse also too. So these things interact with each other, of course, and that the details and the complexities come around the syndemics around the various activities and the various characteristics of individual patients. And ideally, we ought to design the discharge package around medicines and other things to most approximate what the risks are that those patients have, to individualize the tools that we give them, and that we're working on the tools that can do that now. Relative to depression, we showed in our data that no depression, this is 30-day all-cause readmission rate of about, over here, about 10%. Moderate, which is PHQ 10 less than 9, and then greater than 10 is much greater. So it's a dose-response relationship to depressive symptoms and rehospitalization. And patients with depression are more likely to not use their medications right because their memory isn't the same, their motivation is not the same. When we asked people with depression after discharge, how well do you understand your appointments and your medications? Those with moderate to severe depression didn't understand those things as well. So the health literacy activities, perhaps, not just literacy level, but other factors ought to be considered in the kinds of education we give, like depression. We have a randomized controlled trial going on now, enrolling only people with PHQ levels less than 10. How well did you feel you understood your primary diagnosis? Those with moderate to severe depression did not understand their diagnosis even as well if they had depressive symptoms. So these combinations of factors are things that I think are the future of health literacy. So it's not just screening for health literacy, but what other combinations of diagnoses and comorbidities are there? Let's discuss this morning a little bit about what is sort of the process. And I don't have a lot of time this morning to go through this, but we put together a list. Of what the schematic would be about the patient's discharge with the correct medications. So so failure modes effects analysis is you put together the process map, then you measure in between each of these things what's the quantitative probability of failing that step. So we've done a lot of that kind of work. We know that our hospital patients discharge on correct meds. So getting the prescription, receiving the prescription from the intern, so you're giving new medicine, did it actually get sent to the pharmacy or given the script? We know that 2% of the time that doesn't happen at our hospital. So you can add that up and then look at those probabilities and see what the total probability is. And we know in our hospital that when we call people 1 to 2 days later, that half of our patients are doing something incorrectly with their medications. So and then we also have stories. I don't have time today to tell you, but for each of the failure modes in between each of those steps is a story that illustrates what that's like for individual patients. It really brings it home. And these are real people who have real problems. And then one day somebody came to my office and they said, here, take a look at this. And this is, you can see here, is the third page of that NCR paper. We don't even use so much anymore, but you write really hard, and then the first page goes to the chart, and the third page is that pink page that goes with the patient. This, I would say, is really still the norm rather than the exception in America. And if you look carefully at this is where the medicines are here, and somewhere in there it says nifedipine 1 POTID. It's in Latin, for goodness sakes, if you could even read it in the first place. This is the discharge instructions for patients to go home. Now, we go to school for years and years to know what that medicine is for this diagnosis and those two medicines and all that. We go in the room, spend 2 or 3 or 4 or 5 minutes, and expect somehow magically that people are going to understand all that. The tools, this is such an important meeting, because the tools that we need to develop are possible, and patients really deserve to know what to do. They want to know what to do when they go home about how to care for themselves. Just for 1 minute, I want to talk about a new project now that PCORI is funding, which is Project Achieve Qualitative Analysis. The Project Achieve is a 3 or 4 year project with PCORI to look at what in transitions in care is important and for whom. So we did a lot of the qualitative work in the first year, and you can see it's a very large study with 35 focus groups and 72 key informant interviews and 2,000 pages of transcripts. But what we found in one slide is that the things that are important to patients when they're leaving the hospital is communication. That communication is really critical. That it has to be purposeful, it has to be supportive, and it has to be collaborative. We need to anticipate their needs better. And this is all related to medication instruction at the time of discharge and health literacy. that medications are especially important to patients when they leave the hospital. And continuity of care is important too in terms of relationships, information. But this concept of unambiguous accountability is really, really relevant to the medicine part of it. Who is it that is unambiguously accountable for the patient when they leave the hospital to answer their questions in an informative kind of way? And that's something I think we need to get to, because patients tell us all the time in this very large qualitative study that they don't feel comfortable. It's important to them to know who it is that's responsible, and they're not getting that information a lot of the time. So my final thoughts are that the range of discharge improves transition to care from hospital to home, that the after-hospital care plan is the active ingredient, that RED benefits those with low health literacy, that depressive symptoms and other comorbidities impact the ability to understand discharge instructions. And the syndemics of health literacy, I think, are something that we can do a lot more work in. And that outcomes important to caregivers and patients include communication that is purposeful, supportive, and collaborative. Thanks very much.